Right then, so today we're going to talk about the challenges of cavity wounds. I suppose the first question I should ask you is, do you have a challenge with cavity wounds? Do you? All right. Okay. I have a challenge with my wife. Maybe she's a cavity wound. Zoe, if you're listening. Right, so before I go any further and dig myself into an hole because she's sat at the back, cavity wounds. Now, going back in time, is there anybody here from the 70s and the 80s? A few at the back there, a few at the back, a few that are a little bit shy down here. When I say 70s and 80s, I mean practicing in the 70s and 80s. There's a few going down here, no way. Well, I started in the 80s, mid-80s, 86, and obviously by now you can tell I've taken my glasses off. You can tell that in actual fact I was only 9 years old when I started. So I could never imagine being in this job for 37 years. It's coming up in February, 37 years. But I don't know about you lot, it's been one of the best experiences I've ever had. I don't know about you lot, but nursing has been fantastic to me. So going back to cavity wounds, why am I talking about the past? Because in days gone by, we used to pack wounds, didn't we, tightly, and we used to pack them with hydrogen peroxide, Usol and paraffin, acetic acid, and they all stung like hell. And I mean, they stung like hell. And if you was putting it into a patient's wound, you used to see them after about 5 minutes clinging to the ceiling, didn't you, like demented cats. So hopefully nobody is using any of those products now. Is there anybody using acetic acid, hydrogen peroxide, Usol and paraffin, which is bleach basically, and acetic acid is vinegar. So, excuse me, where are you going? So, she's one that's using acetic acid. Obviously, oh Christ, no, where's he going with this one? So, all I will say to you is this: hopefully, nobody is. The big issue, though, is I have a feeling half the audience will be, but you just don't know it. If I was to ask you, does anybody use, let me just think of a dressing, hydrogels? Do you use hydrogels? Yeah, well, we all nearly do, don't we? Does anybody in the room use honey? Yeah. See, I'm lulling you into a false sense of security. I said hydrogels for no reason, just to see if I get a response. The honey made you think, oh, I'm getting a bit comfortable with him now, so I'll speak. And you said yes. Now, honey, when you expose the honey to air onto the wound, it creates hydrogen peroxide. So when they say that honey stings, it's because the hydrogen peroxide that's produced is the stinging effect, but it's also the antimicrobial that kills the bacteria. So it's a fantastic product. But you've just got to be aware, when you open your products up, what is actually in them and how do they react. So if you read the leaflets to all the dressings, it'll give you lots of information. Now, as Sam said, this session's sponsored by Monica. I don't work for Monica. I'm a TVN. I was on duty yesterday and I've driven down this morning at 5 o'clock. I was up at 5 o'clock and drove down at 6 o'clock after walking the dogs. I'll be back up there this afternoon and I'm back on duty tomorrow. So I'm not here to sell you products, but I will mention their product as we go along. So you've got to be, at the end of this, now here's a question for you, I suppose. It says learning objectives. Understand the definition, be aware of the different presentations, understand cavity wound assessment and how it fits into the holistic assessment. Consider cavity wound management and how it's changed. Well, we've just said, so we've done the presentation. Understand the aims of treatment and some practical ways to manage the wounds. Do you think you're going to learn anything at the end of this session? Yes. I'm going to disappoint you. I don't think you will. I think what will actually happen is you'll reflect on your current practice and what we're already doing, and hopefully you'll think, oh yeah, I'm doing that. What we sometimes forget, though, is that we think we're doing it when we're not. So, for instance, on a Tuesday afternoon, back in Hull, I chair a pressure ulcer review and learning panel for the whole of the area. So every datix that comes in that relates to a wound comes through this pressure ulcer review and learning panel once a week, and I have to go through it with the clinical leads, the matrons, etc., etc. And we make sure, or we look for missed opportunities. But what we do, we look for those missed opportunities with a view to not blaming the nurses. We do it as an action learning. So we put together a learning plan where either the TVN, the clinical leads, etc., will work with those nurses to make sure it reduces the risk of it happening again. So all I will say to you, there's a common theme, and we think we're doing lots of the things, but we often miss. We miss out on risk assessments, we miss out on communication, and our documentation is probably not as good as we think it is. And certainly since the, shall we say, the bringing in of electronic records, that's made things a little bit more difficult for us in some ways, hasn't it? Because we tend to do it at the end of the day, and we tend to do it at home as well. So we sat there on a night, now I can't type that fast, so it takes me twice as long to type it as it does to write, which is really frustrating. In defence of electronic records though, what that will do, it will protect you in your day-to-day practice. And should you end up ever in a coroner's court or a court of law, that will be the evidence that says, actually, I did it. And you'll have got rid of all those risks of missed opportunities. So, as we've already said, and you lot have alluded to, thank you, that they can be challenging for us, because the one thing I will say to you is this though, please don't pack wounds. If you take nothing away from today, don't pack wounds. Because all you're doing when you pack a wound is trapping the bacteria in the dead space at the bottom of the cavity. And that allows the bacteria to multiply, and that's when you get your infections. So you need to gently lay in the fillers, and if you can, nurse the patient so gravitational force will let the fluid drain out through the filler, and then you don't have any dead space with any bacteria collecting. May be difficult to visualise the entire cavity, so we may have to refer through to multidisciplinary team. And lack of standardised definition. It's taken us a long while really to get to, in pressure ulcers, hasn't it, grades, stages and now categories. Is there really a difference between a grade, a stage and a category? I don't see that there is personally. It's just another word. You're still using 1, 2, 3, 4, aren't you? Unstageable or ungradable, whichever you're using. It makes diddly squat as long as you can justify what you're doing and you've documented why you're doing it. So, put on a bread and butter wound, shall we say. It's dinner time coming up next, isn't they? So if anybody's just pitched up for a free meal, apparently there's 200 odd of you and there's only about 190 meals. So they said, can you try and put them off with some images? So I'm only joking on that one. I just thought I'd put this up because my background is vascular, and this was our bread and butter to us, in that we used to get lots of forefoots, lots of below knees, lots of above knees, through thighs, all sorts of things. Now, unfortunately, because they're poorly perfused, you get an awful lot that break down. This one obviously hasn't broken down. This is one that's meant to heal by secondary intention, so it's been left open to heal. There's some issues going on though, isn't there? So if you look at the image on your left, the issue that's going on, there's a lot of maceration and probably some callus there, which will not allow for epithelial tissue to jump across that good granulation. There's also, although it's not quite so clear on this big image, it might be better. Are you on screens down the side, or is it just voices? Just voices coming out at you. I'm often getting them. So, in the darker areas, there's some little cavities there. Now, it still means that this wound, because the cavity is greater than 2 centimetres, it still needs fillers putting in. And we need to really look after those wound margins. So I always use the example of my lad. He's only 14 now, but when he was a bit younger, he was into swimming. So I always used to say to him, Louis, before you dive in, always look at your feet first. So he said, why, Dad? So I said, look at the floor, make sure it's clean and dry, and if it isn't, do it with your towel first, and then get ready to dive. He said, why? So I said, because if you slip, you're going to just belly flop into that pool, and all your racing colleagues are going to be up the pool, swimming an awful lot faster than you. You'll be thinking, Christ, what's he talking about now? Well, it's exactly the same with a wound. If you don't protect that wound margin and it's wet or excoriated, the epithelial tissue will stand there at the side of the wound margin and it'll try to jump in and swim across the granulation tissue that's filling up. It won't make it, so it belly flops in and you get a static wound. So it's vital that you look after the peri-wound skin as well. Next one. So no real definition, as we've said. since the 90s there's been lots of attempts to define it. What I would say to you is this: a shallow cavity is 2 centimetres or less, a deeper cavity is 2 centimetres or more. There are certain foam dressings that will conform into a 2 centimetre cavity without the need for a filler. Once it goes beyond 2 centimetres though, you will need to use a filler, but just remember, please don't pack, just gently fill. Intimate contact with the wound margins going down into that dead space. Now then, where do they exist? Well, they exist everywhere, don't they? As it says up here, it can be a chronic wound, it can be a traumatic wound, it can be a surgical wound, it can be an abscess. Now then, if we just very quickly go through these, chronic wounds, just by definition, how long is it before a wound is becoming chronic on terms of days, weeks, months, years? 2 weeks. Any more offers? 6 weeks, I can hear it. Either that or somebody's whistling at me. 6. So it could be 2, it could be 6, it could be 4. Who the hell knows, really? I would probably challenge that. And if you look at the National Wound Care Strategy at the moment, they're suggesting, and I've suggested for years, to be honest, that a wound can be chronic from day one because of the underlying etiologies that's causing it to be there in the first place. So if you've got a compromised patient, i.e. they've got somebody who's, I don't know, got diabetes, cardiac failure, etc., there's a fairly big chance that that patient's going to end up with a wound that's going to be difficult to heal and could become chronic, complex, non-healing. Traumatic wounds, well, obviously, it is what it says it is. Although it's strange, I still get patients referred through PEL into the pressure ulcer group with traumatic wounds. Yesterday, it was, what was it, a pretibial laceration came through. Surgical wounds, but this is the one that I think may be of an interest to us a bit more at the moment. Going back to the day, palinadal sinuses, what was the root cause of them? What was it? Ingrowing hairs. So what profession of people had ingrowing hairs? Lorry drivers. Should be TVNs that drive up and down the country to Wales and back. Yeah, it was lorry drivers. So it was sort of like middle-aged blokes that were getting these things. Who was the group of people that's starting to get them now? Younger people. Gamers sat in them vinyl chairs on the gaming machines. I'm getting people coming through now into clinic who've had excision and drainage of palinadal sinuses, who have been, the youngest I've had, I think, was 13. It was, yeah, 13. And they're going up into the 20s. So because, I think it's because they sat for long periods of time on those vinyl, sweaty chairs, it's the same sort of thing. You get the ingrowing hairs, and it becomes a problem. Now then, there was some, just in case you know anybody that's got one, or is developing one, or you're one of them that sat there like that, if you ever do, I would suggest looking at the evidence that Doncaster did, and it was, I forgot her name, Kathy Leake and Sue Johnson, they did it. And what they found was if they put a silver filler in after the excision and drainage routinely, instead of leaving it with just a normal filler, put an antimicrobial filler in their case they did a silver, and it reduced the risk of it coming back again. So just one for you to take away, because it's becoming more and more prevalent as we move through. So this is a dehisced surgical wound. So I'm going to ask you the question, do you know what dehisced is? Right. Is there anybody new in this room? Anybody that's a student? Couple of students? There's a few like that. I don't know whether there's a dance going on or what. So there's a couple of students, there's a couple who don't know. Is there any newly qualified nurses? No, so that means you're all old dothers like me. So there's no newly qualified and only 2 or 3 or 4 twitchers that are newly that are students. Now then, up in the north of England, I don't know whether the study is the same as ours, but you get very little access to wound training. And because the way that you work these days, in my day, you had to do 2 years in the acute before you could go out into the community. Well, now you can go a direct pathway straight out into the community, which is a bit of a worry because 60 to 65% of the community nurses' workload is wound care. And I guarantee up north, all they've had is half a day in the university saying, this is what a wound is, this is what you do with it. So it means these poor people are coming out fairly inexperienced with not an awful lot of knowledge on wounds, but are expected to know the answers. Whereas in my day, you did 2 years, so unfortunately, I stuck there for another 17 years. I loved it that much on vascular, and I didn't want to leave. So my experience was all based on vascular. So when you get people who say to you, oh, do you know what a dehisced wound is? And they say, oh, yeah, I know. All it is simply the wound is broken down. It's been closed by primary intention, either sutured, clipped, or whatever, and it's broken down, it's dehisced, it's opened up. And it usually dehisces because of bacterial burden. So if a wound breaks down and you develop and you get a cavity, then you need to put a filler in. If it's less than 2 centimetres and you've got a foam on your formulary that can conform into it, fine. If you've got, like it's showing on this image here, on the left-hand side of it, there's that darkened area where there's either some undermining or there's a cavity, then it will need a gentle filler laying in. So, several different presentations that include. So, if you was looking at a 3D shape of a cavity wound, the simplest one is this. It's a uniform shape. As I keep saying, if it's less than 2 centimetres and you have a foam on your formulary that can conform, then that's absolutely fine. Does anybody know what this foam is that I keep wittering on about? I don't know what I can tell you then, it might be top secret. You'll have to ask me quietly at the end. Now then, so cavity with undermining. Now then, again, do you understand what undermining is? It's as simple as this. So if I was a coal miner, I bore a hole down to the level of the coal, and then I start to horizontally mine outwards, don't I, and get into the coal face. It's exactly the same. There's a smaller hole at the top, and then it widens out, and what you've got to do is palpate around the skin at the top to find where it starts to go, and there'll be no tissue underneath. We don't feel as much as we used to do we? In the 70s and 80s, we were known to sit on the end of the beds and have a chat with the patient, hold their hand and touch the skin and all that sort of thing. Can't do that now, can you? It's cross-infection. Can't do it. But yeah, please get a gloved hand on and feel, palpate around that wound margin and see if there's any undermining. Take a probe and make sure you put the probe in gently and see where it probes down and around to, and record it and document it. So this is a cavity wound with a pocket. Now if you get a pocket in the base of a wound, so it looks like little, it's not just one like that, it could be little craters in the bottom of your wound. That granulation may look like the moon's surface, so little craters at the bottom. If you get that, it's a fairly good indication that you've got bacterial burden there, and that wound, I guarantee, will be fairly static. So you need to again consider, do I need to give it a 2-week challenge of an antimicrobial? I would also consider, do I need to clean it or debride it? Just a quick question, how many people in this room debride? Just put your hands up. 1, 2, at the back. 3, 4. There's only 4 out of 210 people that debride wounds in here. I think you're all here for that bloody free dinner, aren't you? Is that because you're assuming that I'm talking to you about sharp debridement? Yeah. Well, it isn't really, because what we've got to think is every time that we put a dressing on a wound, we're helping the wound autolytically debride. Every time we mechanically debride with a cleaning cloth or a debridement pad, then we are debriding. And it should be part of your care for that wound and that patient. If you've got a static wound, it's highly likely that it's static because it's got a high bacterial burden. And you will not be able to kick-start it back into action unless you clean and then put your antimicrobial on. Now then, this is not part of this presentation, but I'll talk to you about it anyway, because I've drove all this way. I might as well talk to you about anything I can. Right. How many times a day do you brush your teeth? Twice. 3, somebody said. Why do you do it 2 or 3 times a day? To remove the biofilm. Right. So, you remove a biofilm. What is it? It's a polysaccharide coating that goes over the top of your teeth. It's put there by the bacteria and it protects the bacteria. You get them everywhere. We're covered in biofilms. Our teeth especially. Wounds are covered in them potentially. Every chronic wound, which we're saying could be 2 weeks, could be 4 weeks, could be 6, or it could be from day 1, has a biofilm. What we're not quite sure on is how many percentage of those biofilms will stop a wound from healing. But certainly there's a good percentage that will. Now, if I was a vandal, I'm down at the Eden Project. I've got big biodomes. Have you seen it at the Eden Project in Cornwall? And it basically allows plants to grow in the cold air. Now, if you was to break that biodome and let the cold air in, the plants would just shrivel up. Well, it's exactly the same with these wounds. These have got biodomes of polysaccharide coatings that the bacteria has created to allow them to thrive and grow. I'm not suggesting you're a vandal and you take a brick and throw it at somebody's leg, because that's assault. But what I am suggesting is the only way that you will break a biofilm is to mechanically remove it. And then what you do, you break it down and it opens up a window of opportunity for 24 hours, and that's the time you get your antimicrobial straight on and it stops it from reproducing. So we've got to do this as part of a jigsaw. So it's not just about cavity wounds, it's about how we manage wounds in general. There's got to be, if you like, either a jigsaw or follow the yellow brick road. You're going along, you're picking up parts as you're going along, and the solution is always going to be with you. It's not the dressings are just the icings on the cake. It's always going to be you, the clinician. So sinus with a blind-ended tunnel, so your pile and ardle. So you've got this on here. What it's showing you is a very small opening at the top, a bigger bulbous area at the bottom where the hair follicle was. You've had excision and drainage. This becomes your dead space. This is where the fluid collects. So if we're not able to get a filler down to the bottom and then allow the patient to allow the fluid to drain out, because we're keeping them off it, which we taught to do in our nurse training, aren't we? Oh, keep them off the pressure point. But you've got to let them come out, let that fluid out, and then you won't have the dead space and you'll get a wound that will heal. Fistulas. Now, obviously, if you've got a fistula, you've got interconnecting sinus that's going from one organ to another, then that's a big problem. And again, going back to my days on general surgery, we used to get an awful lot of these with regards to bowels and fecal contaminants leaking out into other places. So it's a big issue for us, isn't it? If that happens, we've got to refer on to either a surgeon or part of the multidisciplinary team, and we hope that they will see them in a decent nick of time. I don't think I've got an image on this presentation, but I have got one of a young lady that I saw many years ago, and the surgeon discharged her home and said, "Oh, don't worry, that wound will be fine." And then she had this abdominal wound that was all excoriated, and it was like a baboon's bum, if I'm describing it. It was red raw, burning with excoriation. Poor lady's only on 40 odd, and she's laid on this chaise lounge thing, sat forward because the nurses had taken the dressing off to say hello, and as she sat forward, it just it erupted like a volcanic eruption. And I said, "Oh, sit back, you're all right." And she said, "Oh, the surgeon sent me home like this," and he said, "Don't worry, it'll seal itself up." It wasn't going to seal itself up. So I rang him up and I said, "Hey," I won't say his name, I said, "Hey, you've got to have a look at this lady for us, take her back in." He said, "Oh no, it'll self-seal it up." I said, "It won't, she's got a sinus, she's got fecal contaminants leaking through." So he took her back in and did a bowel resection. So, if in doubt, don't do now, do something about escalate. So what this image is showing you is, obviously, hopefully this will never happen in real life. We've got a fistula that's going from organ to organ on the left-hand side as you look at it. You've got your sinus, your pile and ardle potentially with its dead space and its collection. You've got your pocket in there that's going to trap bacteria as well. Now, the one thing I haven't mentioned is what you'll sometimes see is epithelial tissue stretching across the cavity. It doesn't have to be 2 centimetres with a suspension bridge on it or something like that, but it could be just a superficial wound with epithelial tissue stretched across. If you see that bridging effect, that is also a very good indication that the bacterial load in that wound is high. So it needs to be cleaned and it needs to be prepared and it needs an antimicrobial because it's not good healthy granulation or epithelial tissue. This one is a cavity wound here of somebody's knee. Strangely enough, in a past life, should I declare this to you? In a past life, I used to make women's shoes. Obviously, I was only 7 then. So before I came into nursing, that's what I did. I did quality control. Now, this lady, her husband was the owner of this company, and I'd then turned up many years down the line. She'd been discharged. She'd had a hip replacement done, and she had a dehisced hip wound. So she was discharged home with this hip wound, with the instructions had been from the surgeon, pack this wound tightly. No. Pack this wound tightly, he said, with proflavin ribbon soaked in proflavin. So I said, no. Proflavin was only ever licensed for superficial abrasions, if you slipped over or something like that. Not for packing wounds, and please don't pack wounds. So the poor nurses in this private hospital that had done it were packing. Gets into the community, the nurses say, can you come and have a look at this lady? We're a bit worried about her knee. I said, I thought you said it was her hip. Oh no, she's got these wounds on her knee. So anyway, I came out and saw this lady. And on her knee was these two little open areas that you can see, but they had like a plug of slough with well, it looked like something white in the middle. So I thought, oh, I dare have a go at that, to be honest. Even with the other job I did when I was 6 was carpet fitting. So I'm really good with the Stanley knife, but I thought I'm not taking a blade to that one. So anyway, I said I'm going to put some maggots on. So I put free-range maggots on, not a bio bag at this time. Put the maggots on, came back, they're all sealed in, came back 3 days later. Oh yeah, they'd cleaned it up all right. And this white thing in the middle was more prominent. So I thought, oh, I'm going to have to take some forceps. Took some forceps to it. Well, I was like a blooming magician. Just kept coming. A couple of white rabbits and a couple of doves came out a few minutes later. I'm not kidding you, there was reams and reams of ribbon. They'd packed it down tight all the way down the femoral bone, and it created the sinus, and the instruction had never been to take it out. So they just kept packing it. So it forced the fistula all the way down. Now, obviously, in real life, I hope nobody would do that. I genuinely hope nobody would do it, because obviously it resulted in a significant issue for this lady. And she had to have further surgery as well. So hopefully we'll avoid it. So this wound actually is one of my patients now. And he unfortunately fell from his bed and ended up being quadriplegic. Can you believe? He was fit and healthy. Anyway, he sits for long periods in his chair, even though it's specially adapted. If you sit for the periods of time that he's sitting, you're going to get skin integrity breakdown. He unfortunately knows better than me and the nurses, and he'll do it his way. And I hate to tell you, but there's about 33% of our population in the UK that are non-concordant patients. So that's a big issue for us to try and manage. And certainly when you're trying to justify it to the managers, hey, why you got this pressure ulcer? Because he won't comply. But he developed this category 4, down to bone. Anyway, he decided he wanted to go to plastics. So he went to plastics. Plastics cleaned it up, and can you believe what they did? Sutured it. Sutured the cavity over the top without putting any negative pressure to bring it back up or anything like that. Just sutured it. Well, what's going to be the outcome? Keeps breaking down. There's no underlying structure that's going to help it heal. So it's just a couple of examples. Me, really, what I would have done and what we were hoping to do was just heal it slowly, keep him off the pressure, put a filler in there, gently does it. If there was a need, we review and we put negative pressure in there and let it draw it back out. But again, the difficulty was because of the positioning of it as well with the negative pressure. So, but it could have been done. It could have been done. So it continues on our caseload now a few years down the line. Most important thing, whatever you take away from any of these sessions today, is the holistic assessment. Invest some time at the beginning. You don't need me to tell you this. The only way you will save time in the long run is invest time at the beginning. So you make a good assessment, a good diagnosis, a good treatment plan, and you document it. And you document it in a way that your colleagues can follow it. And colleague number 2, when colleague number 2 goes in, they shouldn't change that plan unless there's a drastic need to. And by that I mean, if you've decided it needs a hydrofiber dressing with a foam, that's what you put on, and you stay with it. Give it a 2-week challenge. Don't keep chopping and changing, because the wound won't get an opportunity. Address with the multidisciplinary team, if you possibly can, any underlying comorbidities. Like we said, make sure they're as fit as they can possibly be. Chronic wounds do not stay chronic just for fun. It's because somebody is genuinely not well, and it's the body or the wound speaking and saying, hang on a minute, mate, I'm not quite so well inside and I'm giving you this wound, listen to what I'm saying. So it's our job, like Inspector Clouseau's, to find out what's going on. So we do a detailed wound assessment, including location, measurements. Please put a measuring tape next to the wound, measure it, photograph it, put details on it of where it is anatomically, and then if the patient will consent to both, bring one further away so you've got an image of the anatomical position as well. Always please remember though to make sure that you don't put anything in there that shouldn't be in there, heads and any rude bits. Tissue types present and volumes of exudate, so describe what you're seeing. How much as a percentage is it granulation? How much of it is slough? How much is the volume of it? We only use high, medium or low, don't we? I think we can also look at the viscosity as well. Is it hemocerous? Is it like straw that's coming out? Or is it like thick custard? I'm back to the dinner time again, aren't I? Conditions of the surrounding skin. It's vitally important that we note down, is there maceration, is there excoriation, what we're doing to try and help that wound progress. Signs of infection. You can't see biofilms, I can't anyway. If I take these glasses off, I can't see much. But biofilms. They used to say 15 years ago when they first started talking, maybe 20 years ago now, oh, you can see them, they look like shiny coatings over the top of wounds. You can't see a biofilm unless you've got microscopic vision, and I haven't. So you might see one then with a microscope, but you won't see one with our naked eye. What you will see, you may get a shiny coating over the top sometimes, but that just goes along with the fact this wound has stopped progressing down a normal trajectory. It hasn't done 40% reduction in 4 weeks. You need to be pricking your ears up and thinking, hey, what do I need to do? Well, what you need to do is get back to that jigsaw puzzle of putting everything together. So I assess, I diagnose, I treat. My treatment is I clean and I prepare. Simple as that. And if you do that, I guarantee you've invested that time at the beginning and you will get better outcomes at the end. We're not going to get more resources as nurses, are we? They're just not going to be able to pull them from wherever. I don't honestly know, but they're just not going to. So just a few things, how to measure a cavity. So a regular shape one, do it ruler based with a disposable thing. Always take an image if the patient consents as well. Cavity with undermining, you'll need to palpate, like I said, and probe as to where it goes in that coal miner's hole. Cavity with tunnel or pocket, use a probe, take a photo with consent. Be very careful though if it is, just because you don't want to probe too hard. And also, please don't use those hooker duck ones. You know, the old metal ones they used to have, and they used to have like a hooker duck loop on the end. I always used to think, oh, because with us working on vascular, we used to get loads of D-his-fem pops because they used to get contaminated with urine. So they'd break down, and people would be faffing around probing with their metal things. And I thought, if they go and hook that new artery, that prosthetic artery, we're going to have a gusher on the ceiling here. So fortunately, we only had one gusher in all the years I was there, and it wasn't due to a probe. A sinus or a fistula, so we're going to have to use a probe as a first point of contact, x-rays, MRIs, so we're going to have to call in the multidisciplinary team. A few examples of a wound being probed from, obviously the first one on your left, we're looking at the undermining, so we're probing horizontally, and the other one we're probing to see if they interconnect and if they're all part of one wound. Yes, they do. So we're going to have to clean and prepare both of those wounds. What I will say to you is before you do clean and prepare though, always make sure you've got a good arterial supply down to that area. If there's no arterial supply, don't start cleaning, don't start debriding, refer on, escalate to somebody, either your TVNs or whoever's managing your wounds in your area. So, cavity wound management, this could have been me, but it couldn't really because this bloke's got hair and I haven't, so we'll have to just imagine. It's been a long while since I have, but I'll tell you what it does do, it saves you an awful lot on haircuts. So, the management of complex, challenging cavity wounds may require the skills and knowledge of specialist clinicians, surgeons, radiographers, stoma nurses, tissue viability, nutritional support. Just while I remember on that one, nutritional support, if you've got a wound that's leaking high volumes of exudate, that's containing high volumes, a guarantee of protein, that wound will not heal. So remember, involve your dietitian if you need some advice. Otherwise, make sure the patient's taking some protein supplements to kickstart that wound. We've got to give that wound and that patient every opportunity to heal. Less complex shallow cavities can be managed effectively through local dressing use. Yes, it can, but don't pack, only gently lay in. Historically, it was to pack, please don't pack. It's now loosely fill or gently lay in. Wound debridement, well, again, this is what we've already alluded to. We thought we didn't do it, but the actual work goes back to George Winter of 1961. What he did, he scored some insults on pigs. He covered half of the wounds that he created with film dressings, half were exposed to air. Those wounds that had the film dressings on that were warm and moist healed twice as fast as those that were exposed. So that's where we get the plethora of dressings next door. So when you're on your breaks, go and utilise all those companies that have got dressings, find out, touch, feel, and see what they can offer. And certainly if it's on your formulary, make sure you're familiar with it. Read the little leaflets that go with it as well. But the main thing is we're always creating a warm, moist environment which promotes autolytic debridement, which means we're all doing it in one way or another. Focus for infection. Well, again, you've got to be able to recognise, is a wound infected? Have I got an increased exudate, malodour, inflammation, pain? And if I have, I've got 3 or more signs, then I need to be taking some action, whether it's topical or whether it's oral. Try and avoid your antibiotics. First point of call will be your topicals. Causes high volumes of exudate. If you've got bacterial burden, yes, it will. There'll be an increase in exudate, then there'll be an increase in the viscosity. But please don't confuse it with an acute wound that's got a normal level of exudate that's bringing everything to the party. The viscosity will be a lot less, it'll be a lot clearer in an acute wound. Debridement products that can fit inside a cavity. So your pads are very good. So at the moment you've got your Debrasofts, you've got your Old Preps, you've got your Cliniderm pads. All excellent. I'm sure there's many more, but they're just the ones that we've looked at. But they're very good at getting in, cleaning, disrupting biofilms, removing dead and devitalised tissue, preparing your wound bed. And we've said about dressings can facilitate autolytic debridement. So remember, all you're trying to do is create a warm, moist environment and bacteria-free. It might sound easy, but trust me, having done this for, well, being a nurse for nearly 37 years and being a TVM for 22 of those 37, it's really difficult to create that warm, moist environment. It sometimes becomes wet, it sometimes becomes dry. One day when you see it, it'll be very wet. The next day you think, oh God, it's stuck to the dressing, it's gone really dry. So you've got to try and plan. And certainly if you're using compression, always think that once I reverse that venous hypertension in that lower limb, the wound will start to dry up anyway. So my need for higher absorbing dressings will reduce. So the primary dressing should conform to the wound bed, very important, pooling of exudate. So this one is where it starts to talk about effectively about the product that Monica have, it's Exufiber. So you've got to get a dressing that conforms to that cavity and the contours of that cavity without overfilling it. And what they're suggesting with the Monica product is, you've got to think, I need that fluid out of that dead space to come out of the wound as efficiently as I can. So this product, Exufiber, does allow that to happen. It removes very cleanly without the fibre shed as well. And it does, if you use the AG version, stops the reformation of biofilm. So, optimising the space where healing happens. It's proven in practice, it's underpinned by clinical evidence, and it's proven to be cost effective. Now, I would argue, and I shouldn't say this, I don't suppose, but I would argue that any product is cost effective if you, me, you, us, collectively use it appropriately. And the only way we'll use it appropriately is if we do that good assessment, that good diagnosis, and that good treatment plan. Remember, the dressing is only the icing on the cake. It's up to you. As Paddy McGuinness would say, the power is in your hands, and it's up to you. And what's his next say? No likey, no lighty. Just watch out, because the spotlight's coming on in a minute. So, what we're trying to achieve is to absorb and control the exudate whilst allowing free drainage. Because if it stays in that dead space, that's where we get the infection. So gently fill them, not forced in too tightly. Don't have packing competitions. I'll have to put my hands up. In the 80s with my colleague, we used to have competitions with ribbon gauze. Oh, I got 1.5 foot in today, Paul. It's funny because he's now the manager of neurosurgery at HRI, and we still meet often on the weekends. I'll go and watch his lad play football and he watches man play rugby. And we have a laugh we reflect on some of these things that used to go on in the 80s. It's once so good, really. So it could cause local blood flow to be restricted. So if you pack too tight, effectively, it could stop the microcirculation. Also, if you should turn somebody onto a side where you've packed tightly, it will cause further pressure damage. So be really, really careful. May hinder granulation because of that, because you haven't got a blood flow there. Primary and secondary dressing to use effective transfer of exudate. So again, when you're choosing your dressing as your filler, and if it's allowing the exudate to come through it at a nice steady rate, the secondary dressing that you choose has got to be able to absorb that exudate and lock it in without it laterally wicking. Because if it laterally wicks once it's through there, all it does then is excoriate and macerate the peri-wound area. So you're going to be no better off. So select your dressings really carefully. So this is an example of a filler that's been used. Now I would suggest that is overfilled. I'm not saying it's overfilled to the level of we used to with a ribbon gauze, oh yes, but it's still overlaid and overfilled. It'll allow for exudate just about to get through, but what I'd prefer is if we just laid it around the cavity wall in this particular case, down to the bottom and let it drain through. That's all you need to do. Don't overfill, don't overfill. So, cost of inappropriate dressing, adequate assessment. So if we don't get that bit right at the beginning, it's going to be a problem. Better wound care, including the diagnosis, we've got to get that bit right at the beginning. May also have an impact on the patient's ability to independent work, living, etc., etc. If you get a patient that can't go about their activities of daily living as they normally would, and they're in pain, and they've got maceration, and they've got burning, itching skin, they're not going to be concordant, are they, and compliant? And then we have that 33% starts to increase, and you start to think, why am I spending 1.2 million instead of 1 million on dressings? Why am I doing 5 or 6 visits extra a day when actually it's all because we've missed our opportunities with our assessment? It's the only way, I'll tell you now, if you feel you're on the hamster wheel, it's the only way you're going to get off. Invest to save at the beginning. All right, I know it sounds a bit harsh, but it is the only way. So, as you said at the beginning, cavity wound management may be challenging, but I would say it's only a small part of the challenge of wounds per se, and the same with patients. The challenge is the patient, and if we can get them to be in a good relationship with us, then there's a far better chance that we will get better outcomes. And you know, they used to say, well, they still do, 72% of lower limb wounds will heal with compression at 40 millimetres or more in 12 weeks. That was gold standard. And then they used to think, well, why doesn't it happen? Because one, there was some missed opportunity right at the beginning that either didn't get them into the right 40 millimetres of compression, or the patient had it on for a few days and said, I ain't tolerating that. And it was basically because we didn't communicate with them what the expectation was of that wound. And it is about that partnership working with your patient. You as the multidisciplinary team, we're all specialists, but we don't cover everything, so use them. Remember, good documentation is a must. Effective management will lead to reduced pain, improved quality of life, better outcomes, and more concordant patients. So the challenge is for us as healthcare practitioners, can we put all those things in place? Now that completes mine. Have I done it in time, ladies and gentlemen? Marvellous, marvellous. What I will say to this, I'll ask you a question. Have you learned anything? Yes. Have you? Yes. Fantastic. I'm thank you for that, but just remember that you are reflecting on your practice to make things better for us all. All right. And the one last thing to say, because this is the last one, isn't it, before Christmas? First of all, have a fantastic Christmas to you all when it comes, because I've noticed decorations are going up all over the place, so have a fantastic Christmas when it comes. Good luck with your careers in the NHS, certainly for those students and those newly qualified that are coming through. Best decision you'll ever make in your life. It'll open so many doors. So enjoy every second of it. Sam, over to you.
Thank you, Simon, as always. Gosh.